Hello everyone. Here I describe the basis of therapeutic drug monitoring. It is a competency number 1.2 pharmacology, and this is a part A. The definition of therapeutic drug monitoring is that is monitoring the response to drug therapy by measuring therapeutic effects. Therapeutic effects can be monitored by estimation of plasma drug levels or by clinical assessment or by laboratory tests in blood, urine, or as microbiology. Let us basically understand the facts. Many factors such as genetic influences, concurrent drugs use, and diet alter pharmacokinetic features of the drug, and this results in wide variation in the blood levels and therapeutic effects. May result in toxicity as well. Drugs follow first order kinetics of elimination or zero order kinetic of elimination or a mixed order elimination kinetics. For several drugs, a predictable relationship is there between the drug levels and desirable or toxic effects, and there are methods available for estimation of plasma levels or a marker for therapeutic effects such as prothum and time. Dose adjustments can be done to achieve desired therapeutic effect and avoid toxicity. Let us understand the safety margin or a therapeutic window of a drug. Is a hypothetical drug A whose dose range in therapy is 10 to 60 mg per day, but when dose is increased from 100 mg onwards, toxic manifestations occur. But there is also a drug B whose dose range is 0.25 to 0.5 mg only, and toxic manifestation begin at doses 0.5 mg. This is the dose response curve of the dose effect curve and dose toxic effect curve, identifying the minimum effective dose and maximum tolerated dose, and one can see a notable wide gap between these two doses at horizontal level, and the gap between these two is wide, so we can say that this drug A has a wide safety margin. It is denoted by a term therapeutic index, that is maximum tolerated dose divided by minimum effective dose. For drug B, when we plot the therapeutic effect curve versus toxic effect curve, we find there is a narrow dose range between these two, and therefore drug B has a narrow safety margin. Of the most important notable point is that even at 0.5 mg dose, the red triangle shows that some toxic manifestations have already occurred. An example of such a drug is digoxin, and therefore drugs with narrow safety margin, dose enhancement or reduction or increase should be done very carefully, and plasma level monitoring will be most helpful. There are methods which are used for therapeutic drug monitoring. One method is clinical response. An example is bronchodilation, which can be measured by comfort of the patient and also by FEV1, forced expiratory volume 1, with bronchodilators drug like terbutaline. And second is propranolol, where pulse rate can show the clinical response or reduction in the blood pressure can show the response. There can be in vitro laboratory tests which are commonly done for dose adjustments in warfarin, that is peak prothrombin time, INR ratio, and for bacterial infection, culture sensitivity tests can be done. Quantitative tests are also available to find out the dose response relationship of an antibiotic. Plasma concentration estimation to find the target drug concentration is commonly done for certain drugs, and some examples are, more examples come later on. Some examples are lithium and Now, furosemide, propranolol, levodopa, carbidopa, all can be monitored by clinical examination and usually do not require, whereas levothyroxine, atorvastatin, glimepiride, warfarin are the examples where blood tests will be sufficient, not the drug levels, but the other tests which help. For example, TSH levels will be reduced when thyroxine is given in a patient with hypothyroidism. Atorvastatin causes reduction in the lipid profile, notably LDL-C levels, which can be reduced and a target dose can be achieved, we know, as far as possible in patients with risk factors. Levels should be kept as low as 100 milligram percent. Glimepiride is an anti-diabetic drug whose excessive doses may cause hypoglycemia. Therefore, target level can be achieved by estimation of hemoglobin A1C 3 monthly or fasting blood sugar regularly, such as home glucose monitoring. Warfarin dose is regulated, as I told you earlier, by prothrombin time INR ratio. Any ratio less than 2 requires slight use. Therapeutic drug monitoring by plasma level estimation of drugs is based on certain assumptions, that is, plasma drug concentration versus drug effect are related, and wide inter-individual variations cause marked fluctuations in the plasma levels with therapeutic failure or toxicity, and this can be varied with finding out the level and adjusting doses minutely. Saturable elimination, zero-order kinetics, genetic factors, concurrent disease, and concurrent administration of many drugs that interact, inhibit, or induce enzyme may result in therapeutic toxicity or failure. And for all such drugs, therapeutic plasma level monitoring would be required. It is also assumed that in order to get a plasma reliable level of the drug, a reliable method of estimation should be available. For example, HPL. Now, some examples where plasma monitoring is very helpful are antiarrhythmic drugs, digoxin, lithium carbonate, anti-transplant rejection drugs, cyclosporin, tacrolimus, anti-TNF-alpha drugs, voriconazole in particularly, gentamicin, tobramycin, amikacin, aminoglycosides, vancomycin, many anticonvulsants, particularly phenytoin and phenobarbital, and theophylline. They have characteristics which require plasma level. Now, what are the indications? Drugs with low safety margin, digoxin, phenytoin, theophylline, lithium. Drugs which show wide inter-individual variability, tricyclic antidepressant, lithium carbonate. Dose adjustments in organ disease, chronic renal disease, aminoglycoside, vancomycin. Acute poisoning with drugs like paracetamol, aspirin, alcohol intoxication. Antimicrobial failure to identify the right drug and right dose, MIC and MBC, minimum inhibitory concentration, maximum bactericidal concentration are to be measured. Rarely to assess patients' adherence to therapy, for example, antidepressant therapy or antipsychotic therapy. And finally, revision of maintenance dose for drugs which obey first order kinetics is done by plasma. A revised dose will be previous dose, target steady state plasma concentration, and measured plasma concentration. That ratio will tell us how much division of the doses to be done for drugs which follow first. We must understand that steady state plasma concentration is achieved after 4 to 5 half-lives, and it is the time when we should take the plasma level for change in the. But timing of estimation, that means timing of blood sampling, usually trough steady states are taken for measuring the levels of long-acting drugs or drugs for long-term use, such as lithium, anti-TNF antibody levels, and for short-acting drugs 1 to 2 hours after oral absorption or parenteral absorption is the right time. So post-absorptive phase would show peak levels. The difference between peak and trough levels are shown in the pictorial below, and it should be understood that trough levels are commoner to be taken. For intoxication of the drugs, immediately at the time of entry and then repeated again after assessment of the patient and depending on the rate of clearance. For checking clearance, random for digoxin, a sample 6 hours after last dose is taken. For lithium, just before the next dose is usually done. And for gentamicin, a sample is taken 1 hour after giving parenteral. Plasma concentration is not worth measuring because it will give little information when the dose titration can be done quickly and easily by lab tests or clinical examinations. And most of them are to be given for long time. Their effects outlast their blood levels. Prothrombin time for anticoagulants, blood pressure for antihypertensives, body weight for diuretics and beta blockers, blood sugar for antibiotic drugs, and level of consciousness for general anesthetics. They are as good or better than plasma level. Sometimes plasma concentration has a poor correlation with the drug actions or effects. For example, highly protein bound, particularly basic drugs on the alpha-1 acid proteins will have very varied blood levels of free concentration of the drug because in inflammation level of the glycoproteins is increased. Therefore, lidocaine diisopyramide will bind to these proteins which are manifestations of acute phase reactants. Now, increase in total drug concentration is due to increase in the bound rather than free concentration, and that is with thyroxine. Therefore, it is the free thyroxine which is important than total thyroxine, particularly in pregnancy. What is more important that measurement of TSH level is more important in hypothyroidism, and free T3 and T4 are more important for thyrotoxicosis in pregnancy. Concentration effect correlate poor if total drug concentration is measured for drugs like disopyramide or lidocaine. Now, another facet is that assay may not actually measure pharmacology active compound. There may be inactive metabolites which remain longer in body. For example, benzodiazepines forms both active and inactive metabolites. Plasma concentration has no relationship with the effect for drugs which are commonly called as hit and run drugs, or those which are irreversible inhibitors of the enzymes. The classical example is aspirin in low doses is a cyclooxygenase inhibitor of the platelets and the effect lasts for 7 days. In a similar token, proton pump inhibitor omeprazole is irreversible inhibitor of sodium hydrogen ATPase pump in the gastric canaliculi, and the effect remains despite the fact that drug is not there. Therefore, such drugs we do not require the plasma concentration of drug. As for organophosphorus poisoning, because cholinesterase enzyme can be estimated in plasma, so it is not the drug level to be measured, but the cholinesterase enzyme estimation as pseudocholinesterase enzyme will be more meaningful for management. Prodrugs and anti-cancer drugs, not all but some, are also of the same type and therefore their estimation. Now, some example of therapeutic drug monitoring: aminoglycosides have characteristics which necessitated estimation of blood level to avoid nephrotoxicity and ototoxicity, and therefore their blood sampling can be done. Peak occurs in 3 to 60 minutes after dose, therefore, and trough occurs just before next dose. Therefore, trough levels can be measured for. Phenytoin is a characteristic drug which obeys saturable kinetics of elimination or zero order kinetics elimination, and we can see that therapeutic level of 10 to 20 microgram dose. If dose is slightly increased, the level may reach more than double, and at this point dictates that plasma levels will be very helpful in fine adjustment of the doses, and dose increments should be done in smaller amounts after full therapeutic effect is nearly achieved. Usual dose is 100 mg 3 times daily, but someone requires more than that, then increase dose by 25 mg only. Theophylline also belongs to this category that obeys saturation kinetics, therefore is likely to cause toxicity when incremental. Anti-epileptic drugs particularly require therapeutic drug monitoring to guide dose adjustments when formulations are changed, to achieve control of breakthrough seizures with one drug, when an interacting medication is added and treatment failure occurs. During pregnancy it is done, and to establish an individual therapeutic concentration range when a patient is free of convulsions, and to determine whether adverse effects are related to the drug or some other cause, and to assess the adherence sometimes. This is important because seizure-free interval is most important to. Lithium carbonate is also another example for therapeutic plasma level monitoring, and this is done usually to maintain a therapeutic range of 0.6 to 1.2 millimoles per liter. It is done at plateau level, pre-dose estimation, and we should not collect blood in lithium heparin tubes. It should never be used, otherwise it will interfere with lithium estimation. Blood sample taken prior to morning dose as close as possible to 12 hours after the evening dose. That is very important. Lithium intoxication would occur when levels are more than 1.5 millimole per liter. Therefore, the lithium has narrow therapeutic index. Digoxin is yet another example where therapeutic monitoring is tremendously helpful. Its pharmacokinetic characteristics are narrow therapeutic margin, larger volume of distribution, large number of drug interaction and disease, and its predominant excretion through renal mechanism. And large number of the intervening diseases and electrolyte imbalance. Administration of drug would result in changes which may increase or decrease